nervous. But I'm thrilled to be here and just want to congratulate all of you on being here at this point. Getting to intern year, I know it's a major achievement, and I'm sure you're all very excited about hitting the wards and getting involved in patient care. And so we're going to talk today about one of the things that might make us all a little anxious, and will certainly be something you experience as part of your intern year, and that's an approach to a rapid response. Moving ahead, trigger warning. We do have some pages in here. This is an experience everyone is going to have, is being called to a rapid response. Just to start out with, so we're all on the same page, what is a rapid response? And it's essentially the point at which more help is immediately needed to take care of a patient. And that could be additional nursing, respiratory therapy, critical care, and it can happen for all kinds of reasons. It's really like a wide variety of things that can trigger a rapid response. The patient can simply just look sick. You could have a change in the acuity of the vital signs, a decompensation. There can be instability, and that can be defined in all kinds of ways. The needs can be too high for the acute care floor and in a rapid setting. And so when you come to a rapid response, the challenge is that unlike a code blue, for example, where you pretty much know okay, patient has lost the pulse and we need to move ahead with compressions, we have a pretty standard algorithm. With a rapid response, it could be the patient is pericoding, or we could be called for an abnormal vital sign, but the patient is watching, the Seahawks game and is annoyed that everyone's in there. You can have a whole wide variety of things that are going on. And so, that is part of the challenge of a rapid response, is that you can have all kinds of things go on when you're getting in there. And so I just want to feel free to unmute and say talk, or throw something into the chat. But I'm curious, we're pretty early on. You guys have only been on for about a week or so, but has anyone actually been in a rapid response so far? And I'm just curious to get a sense of if you have, how did it feel, and what were some words that you'd use to describe your experience?
Hey, can you hear us?
I can hear you.
Okay, all right, you can share now. You're good.
Okay, I went to a few rapid responses for hypotension. It's definitely a little worrisome, just walking in and having the nurse kind of bombard you with all this stuff. But I think definitely hearing from the nursing was the most helpful part of it. Especially if you're not super familiar with the patient, if it's only been some or something, they'll know best if they've acutely changed. But overall, it was a tiny little old lady, and she's always less than 90 pounds. There's a slight dip overnight, and she was a little delirious, so it's hard to tell if any of her signs and symptoms were from actual hypotension or just kind of who she is.
Yeah, a lot of stuff I'm hearing, a lot of stuff coming at you in the chat. Someone mentioned that it was chaotic. You're kind of trying to differentiate quickly whether the patient is sick. Are you worried, or is this something that we can take our time with? I think I just want to normalize the experience of going in there and having it be a stressful experience. And our goals really is to help you with some early frameworks, so that you can kind of make sense and organize what is going on with the session. I'm going to I think
VA
Alex
politely. Oh yeah, VA politely has their hand raised.
Oh, please, VA.
Yeah, sorry, you can't really see me in the corner here, but we had a situation in clinic yesterday. It wasn't a rapid response, but it was a code stroke during a physical exam with a patient, and that was definitely stressful. Also, because I didn't know how to call a code stroke, and so it was running around just trying to find someone who could help me, and then having them come in. And thankfully, my attending was there. But definitely stressful, especially because it was still pretty undifferentiated. Could have been a stroke, but definitely could have been something else. So we just didn't really know what was happening and why he passed out and went unresponsive. And now he's in good hands with other interns here. But yeah.
That is very stressful. I think I recall hearing that called overhead here at the VA. But I think like I just want to call out just immediately like getting help, right? Is an enormous like it's a skill and it's something that we all need to be doing. And like I just want to call out and commend you for doing that when like things are, you know, are getting challenging. You don't know, like look around and see who's there and see who you can bring into the folds, because that's going to be a huge asset in terms of like how you are advancing the care of your patient. So thank you all for experiencing 1 week in. We're already like having these tremendous like experiences, really you know, getting into some challenging and unstable situations. And I don't think it's going to be a surprise for anyone to realize like that's going to continue as you move on in your intern year. Alex, are you Alex Collis, are you on the?
Yep, I'm here.
Okay, cool. Do you want to take
Yeah, sure.
take over from here?
I'll take
Okay.
over. Thank you, Dr. Reichel. Hi, everyone. I'm Alex Collis. I'm one of the hospitalists at UW Montlake. I'm currently on service, which is why I was a couple minutes late, but excited to join you all. I'm one of the core faculty for the internal medicine residency program. I co-run our rapid response simulation program, so you'll see me throughout the year with Dr. Reichel. All right, go ahead. All right, so let's talk about what can you see? And I just want to call out, again, we heard from everyone, a lot of can be very chaotic. Our goal is to potentially prevent some of that, but can be chaotic. A lot of different things can come up. And sometimes rapid responses are actually more stressful than codes because you don't have, well, you won't think that you have an algorithm to follow, and our goal is to kind of give you a little bit of that. So what could it be? Could be altered mental status. That's a common thing that comes up. Hypotension, scary when you see blood. Respiratory distress. Arrhythmia. These are some common things that you might see, and this is what our program that you'll participate in later in the year is kind of structured around. And then where can it happen? So most commonly we think, okay, acute care wards could very well be called to that. Could happen when you're on the specialty services. You could be on addiction medicine consults and you walk in, a patient's not responding, and you might be responsible for that patient for the first couple minutes. Could happen on night float and probably will happen on night float. And many of our hospitals, our interns are by themselves. Obviously, you have an attending there, you have support, but you might be the first to respond to a rapid response. Could happen in clinic. It's not what we call it, but you could have a patient pass out on you in clinic or become, unresponsive or something, and you have to act in a similar fashion. And my gosh, you could be walking in or walking out of the hospital and be in the hallway, and you could have something that really resembles a rapid response. So our goal is not to scare you that this could happen anywhere at any time, but to give you some steps to feel prepared and feel like you can act quickly to be able to stabilize the patient. And then you're probably thinking, okay, I just started intern year. I suddenly had a little bit of a reality check. It's been a year since I've done a lot of this material. What happens if I don't know everything? Well, our goal is to really have you walk away today realizing you do not have to know everything. You are absolutely never alone. You're gonna have your senior, attending, other consultants there, stat nurses, which pretty much know how to treat everything because they just go from rapid response to rapid response. You are not alone, and your job as a leader is not to know everything. It's to facilitate. I'm going to give you the idea here. I want you to walk out of this thinking you could potentially step into a situation knowing almost nothing about medicine and still get that patient everything they need because you know how to facilitate. And that's what we're going to work on today. So that's teamwork, knowing how to communicate well in a team, and understanding how to use your resources and what your resources are. So our goal today, we want you to develop a plan for those first few minutes of a rapid response. Again, there are a lot of people here in all of the hospitals that can help you with things, but you might be the first to respond and really need to know how to manage those first 5 minutes. So we're going to give you some tools for how to do that. We're going to review some steps to facilitate a rapid response. So thinking of it really in a more algorithmic framework. So even when you're nervous, you'll have something to fall back on. We're going to review what resources are available to you here at the hospital. How do you pick what they are? How do you activate them? And then just some best practices around rapid response. What we're not going to do today is really get too into the weeds about specific medical emergencies. I think just understanding an algorithm to use to manage a rapid response is a lot to talk about. And I think that really fills up our hour well. And we're going to be doing simulations with you throughout the year where we focus on some of those specific emergencies, really dial down into what's an algorithm to approach those. So our goal today is really just that framework, or how do you facilitate a rapid response? And then I want to bring up this idea for anyone that went here. You know me from transition to residency, and we talked about this, but I kind of coined this term myself, but I think it's actually a really helpful concept to think about. And I call it the well bias. So think back to a time in medical school, either you or someone else saw a patient, was really scared because they looked sick, went and told someone, that person came and saw the patient, said, "They're fine, why did you call me? I'm not worried about it, go see them." If that's either happened to you or someone else, you've seen that happen, that happens so frequently in the hospital that we become embarrassed to overcall things and tend to undercall things. So I want to kind of challenge you on that frame of thinking. So what happens if you underreact? Well, you could delay help. You could have a patient that's really sick and you didn't get the help you need. You might not go see a patient at bedside that is actually sick and needs you to. You're going to miss sick patients. You could potentially cause harm. And then even if nothing's wrong with the patient, at the very least, you might make the patient feel dismissed, which is important. That could be problematic. Now, on the flip side, what happens if you overreact? Well, you'll feel a little embarrassed. If you call people you don't need to, you just apologize, you say thank you for coming, they leave. No harm, no foul. And then what happens, you call your senior in the middle of the night, you're worried about a patient, they say, "You shouldn't have called me. This patient's not sick. You bothered me when I was sleeping." Well, I want you to walk away today thinking that is not a you problem, that's a them problem. As an attending, every single time, I'd rather get called 10 times about a patient that's not truly sick than miss the one time that the patient is truly sick. Our culture needs to change here, and you can be part of that change. We should be willing to help out when people are concerned, when people are nervous about a patient. And if someone is giving you a hard time for your genuine concern about a patient, that's a them problem, not a you problem. You did the right thing. You don't want to miss sick patients. And then worst case scenario, let's say you absolutely are wrong. You call someone, it's not a big deal. Well, you learned something and now you can take that to the next scenario. So I really want you to take away from this, really try and check that well bias, because there's a big kind of culture in medicine that we don't want to be the one that's embarrassed and overcall something, but it really is better for patients to err on the side of overcalling, especially as an early intern when you are still kind of refining your understanding of what's sick, when do you need to act. So really try and check that as you go forward. All right, so we're going to watch a video. You'll see some familiar faces in the events, but this is a rapid response. And as we go through it, I want you to think, what are some of the things that are making it successful? And we'll talk about them in a minute. And we'll play through about I think it's a minute, 58 seconds.
Are you guys seeing it and hearing it?
All right.
Hi, my name is Vince. I'm the senior resident. I'll be leading this rapid response. This is Kyle, my colleague, the intern, who will be working with me. Can you remind me of your names?
I'm David. I'm the bedside nurse.
I'm Alex. I'm the stat nurse.
Thanks, Alex and David. David, do you mind telling me what's going on here?
Yeah, this is Mr. N. I came in to just do vital check and had all this blood all over him, and he says he feels sick. And so I called a rapid, and then Alex came.
All right, sounds good. Can we go ahead and get a full set of vitals?
Full set of vitals. Alex, there's a pulse ox.
Mr. N, can you tell me what's going on, what you're experiencing?
Yeah, I'm feeling really weak and lightheaded. I was just watching TV and then I vomited blood.
Okay.
Sorry, sir.
I'm very concerned that this patient is having an upper GI bleed given this presentation. I'm also looking at him and seeing only 1 point of vascular access. Alex, would you mind establishing 2 large bore IVs for us?
Yeah, sure. I'll put in a second IV.
Thanks. Kyle, would you mind looking up this patient in the electronic medical record? Get a past medical history, most recent H&H, coags, and code status, please?
I'll pull up the chart right now.
All right.
Dr. R, the blood pressure is 89/40 and the heart rate's 126. And satine 94. Is it okay if I put him on some oxygen?
Yes, please.
All right, great. So looking at that video, what are some immediate reactions to, was that a successful rapid response? What were some things that might have been successful in it? Go ahead and unmute or write in the chat. What are some things you observed? Closed loop communication, good. What else?
Yeah. I noticed that the leader was very calm. He didn't panic, and he also took the time to ask for the people's names and roles before starting.
Absolutely, yeah. As someone in the room panics, everybody panics. So we had a very calm leader, spoke very clearly, very slowly, kind of kept the temperature in the room low. Perfect. And then knew people's names, and we'll talk about that a little bit more. That's really important. We have established who everyone is from the start, identify yourself and the team members. It is absolutely valid reason to call a rapid. Yep. Delegating tasks. Definitely. You're hitting all the points here. Good. Any other last observations? Said out loud what he was thinking. Totally. Good. So now we're going to work through it and we're going to kind of break down what you just saw into why was that so successful? What's an algorithmic framework that you could use to look like that during a rapid response? So parts to leading. Oh, Vince, we're in the presenter mode.
Yeah.
Okay, there we go. Okay. Parts to leading rapid response. So starting from the top, we're going to start with primary survey, address immediate stability, and get and use help. And I'll kind of break down what each of those things is. So our primary surveys, as you walk in the room, these are the first things you want to do. You want to get vitals. And I'll give you this kind of little hinter here, or kind of plug for how to do this. So when you walk in the room, always get a fresh set of vitals. The one that's on the board or on the vitals machine could be from several hours ago. And actually, when I get called about a vital sign that's abnormal, I will ask the nurse to go back and repeat vital signs. And I'm not just doing that because I don't believe them, or I'm trying to see if I can make this not really a rapid response. But how that helps you is when you get in the room, there's a fresh set of vitals and the nurse is in the room. So you kind of set up everything you need. So you first get vitals. Then you're going to assess immediate stability. So your ABCs, airway, breathing, circulation. And then the other thing you're going to do with primary survey is get code status. So I want you to think of that almost as another vital sign because it tells you what you can do. So if a patient's DNR, DNI, you might be less aggressive because you can't intubate them and you can't resuscitate them, or you might actually be more aggressive because you don't want to get to a point where you have to intubate them. So it might make you act more quickly, but that's a really key piece of information to have right at the beginning of assessing this patient. And then after we did our primary survey, we assessed immediate stability. Now we're going to address immediate stability. So again, those airway, breathing, circulation. So thinking about airway, what are some things you can do off the bat to kind of temporize an airway and address that immediate stability? You can reposition, you can suction. Think about, are there reversible causes? Is there a lot of secretions in this person's mouth? Is there something in there that you can remove? Can you reposition them? Is this actually code intubation? Do I need to get anesthesia here to intubate? Do I need respiratory therapy? Is this an ICU call? Anesthesia? Is this a surgical airway? And let me tell you, there's a lot of things we can temporize as internists, but a surgical airway is not always one of them. So thinking early, who do I need to get there? Do I need to get the people there for when this gets to a point that I can't really temporize it anymore? And again, I don't want to get into the specifics so much today of like, how do we manage this specific emergency or even shortness of breath or an airway, but just thinking, what are those things you can do in those first 5 minutes to temporize? Next, we have breathing. So thinking, do I need to give oxygen? What type of oxygen? Do we need positive pressure? Again, are there reversible causes? Do I need to give Lasix for this patient that has a lot of extra pulmonary edema? Is this, again, code intubation? Do I need respiratory therapy, ICU, or anesthesia? And then I want to talk a little bit about oxygenation, because this is, you walk into the room, you're thinking, how do I temporize this patient? So I have a question for you all. You are called for a patient with new hypoxemia to 81% on room air. You ask the nurse to start oxygen while you're on your way. How much oxygen do you want? 2 liters, 6 liters, non-rebreather, or start nasal cannula and up titrate until satting greater than 88%. You can either unmute or put it in the chat. And if you abstain, I'm just going to assume you'll just let this patient be hypoxic.
We were saying here that D makes sense.
Okay. We have a vote for D.
Nitrate, yeah.
Any other takers?
Yeah.
D.
C. We vote for C.
Okay. We have a C and a D. Okay. So I would actually recommend D. Oh, we have a B right after it. I would actually recommend C. And there's not really a wrong answer here. But the reason I would recommend C is you have a patient that's acutely hypoxic. You don't know how much oxygen they need. You're probably on your way headed there. I would in a case like this, in a rapid response, I think it's always better to overshoot. So a non-rebreather, and we'll talk about this a little bit more in a second, will give you pretty much as much oxygen as you can get without putting high flow BiPAP or intubating a patient. That patient absolutely may not need this. The patient might need 2 liters. We don't know, but get them on the non-rebreather. It's a rescue measure. And then you can also always dial it down later. But it's a great way to almost like, going into the OR, pre-oxygenating that patient so you can stabilize them and then figure out what you need later. All right, so let's talk about types of oxygen supplementation. So we have, there we go. Okay, so we have nasal cannula. So this is what you're probably most familiar with. So you can pretty much turn this up to 6 liters. You could go higher, but it doesn't really do much after that. And the reason is you have all this entrained room air. Sorry, Vince, could you go back? Okay. So at 6 liters, you're essentially getting like 44% oxygen, and that's because of that entrained room air. So what if you need more? So that's where we can go to our oximizer. So oximizer, that can go up to 15 liters on the wall, and you're going to get quite a bit more oxygen because essentially, I don't know if you all have seen this, but it has like a little well where it concentrates the oxygen. You're still getting that entrained room air, but you can get a lot higher oxygen. So you are getting truly 15 liters. And then next we have non-rebreather. So this I want you to think of as a rescue measure, not something someone can be on long-term, but it's a really great rescue measure. So this also goes up to 50 liters, but it's a non-rebreather, which means literally you're not breathing in anything else. So you're just breathing that oxygen. So it concentrates the oxygen better. Theoretically it's 100%, but in practice it's more like 90%. But the thing with a non-rebreather, it doesn't actually work this way, but in theory, and the way it used to work is you are not breathing in anything else. So if you don't have oxygen flowing through there, you're suffocating the patient. It doesn't actually work through there, work that way. You'll see in real life there's holes and you are getting some entrained room air, but you want to make sure you have the oxygen cranked all the way up to 15 liters. So I actually personally don't place non-rebreathers myself. I always ask the nurse to, because I don't want to screw it up and not have it connected right. So just be aware of that. Always crank it up all the way to 15 liters. Next, we have high flow nasal cannula. So high flow, it's going to get you higher percentage of oxygen, and then it gives you the flow. It's measured in percent oxygen and then liters of flow. Sorry. So this is specifically used for hypoxemia. Gives you a little bit of positive pressure, but that's not really what it's for. It's for hypoxemia. And then lastly, we have BiPAP. So BiPAP is going to give you positive pressure and a higher percentage of oxygen. There are 3 indications for BiPAP, and that's the only reason you should be using BiPAP. Hypercapnia, volume overload, and neuromuscular dysfunction. Patients actually do worse when you use it instead of high flow when they don't need it. So BiPAP is really only used for those indications. The other thing to be aware of is altered mental status is a relative contraindication of BiPAP. Why? Because if you're altered, you stick a mask on someone that's blowing things into their mouth, if they aspirate, or if they vomit or there's a lot of secretions, it's going to blow it right into their airway. So I say relative because sometimes you don't have a choice. Let's say you have, a patient that's DNR or DNI and they're hypercapnic. It's kind of all you have left. So you're going to do it. You're just going to watch them very closely. You'll have them in ICU. They'll be monitored very closely. But do keep in mind, let's say you have a young, healthy patient that's full code, that's really altered. Maybe it's not worth the risk that they aspirate. So you might actually move towards intubation. Again, just to review, because this comes up a lot, and I feel like sometimes people even leave residency not being aware of this, but there are 3 indications for BiPAP: hypercapnia, volume overload. Hypercapnia washes out the CO2. Volume overload helps push the edema back into the blood vessels, and the neuromuscular dysfunction. All of the indications you should really be doing high flow instead. And then lastly, we're going to think about addressing immediate stability circulation. So thinking, do I have enough IV access? Do I actually need 2 large bores? Do I need IV volume, IV fluids, blood, whatever crystalloid is not there, give it back if you can. Do I need pressors? Do I need a cardiovert this patient? Are there reversible causes? And then thinking for, again, getting help. Do I need MICU, CCU, surgery? And again, I don't want to give you any kind of specifics on management today because we'll talk about that during our curriculum. But I want you to think about what are the things I need to do to temporize this patient. All right, and then, so we've assessed immediate stability through our primary survey. We addressed immediate stability through our ABCs, and now we want to get and use help. So as you saw in that video, this is kind of the algorithm I want you to follow. Walk into the room, identify yourself. And as you can see here, Vince is standing at the foot of the bed. So why is that relevant? Well, you stand at the foot of the bed, you can see the patient, you see the vitals machine, you can see everyone in the room. And we tend to associate people just naturally standing at the foot of the bed as the leader. So everyone that walks into the room knows who you are. Now I'm going to tell you, the instinct that I find for almost every intern is to stand where I'm standing in that picture, near the head of the bed. Well, that's where anesthesia stands to intubate. So I don't know if we have any pre-anesthesia people here, but for our internists, don't stand there during a rapid response. If you don't want to intubate, that's not where you should be. And it's okay to kind of wander over there, do your exam and come back, but you really want to plant yourself at that foot of the bed. For anyone that is pre-anesthesia, I don't know if we have those folks. We have those folks, Emily? We do. Okay. So for you, keep in mind when you are playing the role of anesthesia, you want to be in that spot where anesthesia stands. But if you are not anesthesia for the moment, let's say you're in the OR, patient isn't intubated yet, but they're starting to have a rapid response, you actually might want to plant yourself in that rapid response position so people know who you are. And then when you resume the role of anesthesia, go back over to the side of that bed. All right. So identifying yourself, stand at the foot of the bed. Next, you want to identify team members, and if possible, by name. It's really powerful to be able to say someone's name, know their name, get their attention, and have that good closed-loop communication. And then you want to see what roles do we have, what roles do we need, assign roles. And when we meet for our different rapid response simulation sessions, we're going to review and kind of brainstorm what are some of the roles that you can assign. Because people that don't have roles, again, panic. We don't want people panicking in these scenarios. Really thinking, what roles do you need and what roles can people play? And then next, you're going to get the story. Ask for quick history of the events leading up to the rapid response, quick past medical history, relevant meds, and then call your needed resources. So who's going to be number one resource at any of these hospital systems? Your rapid response nurse. This is really, they're available in almost every hospital system now because it's such a vital resource. So their job, they can help assess a patient, figure out what's going on. They go from rapid response to rapid response to rapid response all day. So they're experts in this. They can help with workup and treatment. They can help figure out what additional resources you need and how to get in touch with them. They can also help you triage level of care and help with transfer if that's something that you're running up against. And they can actually turn an acute care room into an ICU temporarily. That is their job. And one other takeaway I want you to have today is do whatever you need to do for a patient wherever they are. If a patient's on acute care, are we supposed to be giving pressors on acute care? No. Can you? Yes. Are you supposed to have an intubated on acute care patient on acute care? No. Can you intubate? Yes. Whatever you need to do for that patient, do it for them where they are. And that's what that stat nurse is for. They're going to be there. They're going to basically set up that ICU for you so you can do what you need to do in the moment. And then I'm not going to go through all this at length. You'll have these slides, but just to give you an example of some of the emergency response teams at the different hospitals. So we have a behavioral emergency, you have a patient's like a code gray, essentially. We have a rapid response team, which is going to be your stat nurse, respiratory therapy, plus or minus the MICU team if you're at the VA. Code sepsis, code stroke, which is stat, respiratory therapy, neuro, and the CT techs. Code STEMI, which activates the cath lab. Code intubation, which gives you the stat nurse, respiratory therapist, and anesthesia. Surgical airway, which gets our surgeons involved. And then code blue, which is stat, respiratory therapy, anesthesia, and code team. And I'll go to the next slide. I'll show you kind of a more simplistic way to think about this. So who do you call? Patient is breathing and has a pulse. That's a rapid response. They are not breathing and they have a pulse. Code intubation. There's no pulse. Code blue. Now, with that said, I want you to err on the side of calling the higher acuity code. So if you have a patient and their breathing isn't great and they have a pulse, just call code intubation, get anesthesia there, they can always leave. If you have a patient with a thready pulse, call the code blue. That's not what the code blue is for, but I'd rather you have the people send them away than err on the side of not activating those resources. And as we kind of talked about on the other slide, each of these teams just subsequently adds more people. So rapid response is our stat nurse plus respiratory therapy. Code intubation gets you anesthesia. And then code blue gets you all those people in addition to the code blue team, anesthesia, or pharmacy, the chaplain, everyone else you would need for code blue. So in thinking about communicating with your team, and some of you called this out, which is really great. How do you optimize communication with your team? Identify team members, Use closed loop communication. So saying, Dr. Reichel, please administer this medication. Dr. Reichel says, Dr. Collis, I've now administered this medication. Summarizing the case. So I like to use the phrase, fill the silence with summary. There's going to be a lot of awkward pauses during a rapid response, unlike a code. Take that moment as the leader to say, okay, we've done this so far for the patient. This is what I'm thinking. And then ask the team for input. Summarize that case. Ask everyone, what are you thinking? What should we do now? And you'll notice during a rapid response, people are coming and going. And if you can take that moment to summarize and keep getting everyone on the same page, it can be really powerful. So putting it all together, let's review again. Walk into the room, you identify yourself, you get vitals, stand at the foot of the bed, assign roles, assess immediate stability, ABCs, the primary survey, address immediate stability, your ABCs, get the story, and then get help. All right, so I'll let Dr. Reichel take over, and we're going to watch that video again and kind of call out some of the things that we talked about today.
All right, so just watching this video one more time and kind of calling out some of the things that we just chatted about.
Hi, my name is Vince. I'm the senior resident. I'll be leading this rapid response.
Leader
This is
identifying
Kyle,
themselves.
My colleague, the intern who will be working with me. Can you remind me of your names?
Getting the team members'
I'm
names.
the bedside nurse.
I'm Alex, I'm the stat nurse.
Thanks, Alex and David. David, do you mind telling me what's going on here?
Getting the
this
events
is
leading
Mr.
up to the
N.
rapid
I
response.
came in to just do vital check and had all this blood all over him, and he says he feels sick. And so I called a rapid, and then Alex came.
All right, sounds good. Can we go ahead and get a full set of vitals?
Getting a fresh set of vitals.
Mr. N, can you tell me what's going on, what you're experiencing?
Yeah, I'm feeling really weak and lightheaded. I was just watching TV and then I vomited blood.
Checking in with the patient, understanding that they have an airway and their mental status is okay.
Very concerned that this patient is having an upper GI bleed given this presentation. I'm also looking at him and seeing only 1 point of vascular access.
Shared
Alex,
mental
do you
model
mind
of what's
getting,
going on
establishing
medically
tumor
and
for
establishing
ID for
concerns
us?
about the circulation.
Thanks. Kyle, would you mind looking up this patient in the electronic medical record? Get a past medical history, most recent H&H, coags, and code status, please?
I'll pull up the chart right now.
All right.
Delegating
Doctor, the
specific
blood
tasks
pressure
to
is
the
89
intern.
on 40 and the heart rate's 126. And satting 94. Is it okay if I put him on some oxygen?
Yes, please.
At the start of any rapid.
Okay. So let me just share again. Okay. Are we back to you seeing the correct screen?
Yep, looks good.
Okay, super. All right. So, yeah, there's a lot of stuff that goes into the rapid response in terms of communicating and making sure your team, and we'll have opportunities to practice that. But just to talk about a few other points to this, you're going to have to get diagnostics, and of course, the idea is like, if a patient, the more kind of acute the patient is, the broader the net you want to have. And this is not the time to really be like thinking about like, what is the exact diagnosis that I think it is right now. You're like, you really want to cast a broad net. And so think about like, what actual tests do you want to order, and like be broad in terms of it, and understand that, when you're getting blood, different tubes allow for different tests, different diagnostic tests. You don't need to necessarily know like which tube goes with which one, but it is helpful to know like that if you want coags, which is going to be really useful if the patient is any concern for a stroke, for example, or if there's any concern for a bleed, like that's a separate tube. If you want a VBG and a lactate, or an ABG, like these are specific things to call out. Asking for a rainbow is like, it's not very specific, and you might assume that's a shared language, but then all of a sudden you're out trying to order a lab and then you realize you don't have something. My rainbow might be different than yours, even though we think it all might be the same. Blood cultures, that's going to be a separate test as well. So be targeted but broad in terms of what you want to get, thinking that like it's better to catch everything in one go than kind of piecemealing it. You'll often have the stat nurses kind of like when they're getting labs, like, what else do you want? Like I've got it right now. Like give me all your orders right now. And so kind of like thinking about what is that broad set of labs that'll be really useful. Other diagnostics, things to think about. What I really want you all to like really like lean on in a rapid response are, what are the things, what is the diagnostic information that you can get and utilize in that room right there? Okay, so a lot of things we get like a CT or an ultrasound or even labs that go down to the lab. Those take time, right? And also may involve moving the patient, which may not be appropriate. You should not be moving an unstable patient. What I want you guys to be really thinking about and leaning on are those diagnostic tests that have results right then and there in the room. So if you're talking about like a VVG or an ABG in the setting of rapid response, that could be a result that you get in the room. In EKG, you can get that right then and there. A chest X-ray, they can take that plain film and you can look at that result right there. So these are going to be the most high yield things. If I walk into an unstable patient, I really don't know, my go-to was like, okay, let me get a VBG, a chest X-ray, and an EKG. And then like, okay, you're going to get a wealth of information right then and there. You know, we all there's a lot of effort and interest in improving and working on our skills using ultrasound. I just want everyone to like, you know, have a caveat that like, this is not only this is a diagnostic tool that you are obtaining the images and interpreting the images. And so I want the weight of how much decision making you're putting on that diagnostic test to be correlating with your skill in obtaining that image. So I'm not the one who actually collects to set up the chest X-ray. If I did that, we would end up with some really wonky pictures and they'd be hard to interpret. But ultrasound, I would be the one putting the probe on and getting the image. And so just like scale the amount of attention and weight you're putting that decision towards your skill and experience using that. You know, think about early on, you know, whether you're going to be heading to the ICU and determining disposition. This can be a challenging situation, and it can be dynamic and changing, but it's something I want you to think about early and come back to. You know, is this something that the patient isn't going to be stable here? Is this something we're going to try some interventions and then we're going to come back and type of reassess? You just want to all be on the same page about this. Make sure that your attending is aware of what's going on. If they are not physically present, they should be brought into the loop early on. If there's an opportunity to update family, this is an excellent task delegation. If there's somebody involved who doesn't have a more like isn't needed for direct patient care right there in terms of stabilizing the patient, updating the family can be really useful. And you know, you want to stay with your patient until you've either like determined that they're going to be stable for the floor and we're going to reassess, or if they're actually going to go to the ICU. If they're going to go to the ICU and they're unstable, you know, you want to be like with the transport team in case of anything is happening. And then of course, like if they are getting a disposition to the ICU, you want to make sure you have a warm handoff, not only necessarily in terms of like the acute events of what happened, what was observed, what did we do, and in terms of diagnostic and therapeutics, but also more broadly, what's going on with this patient that they're taking over the care for, all the, you know, the things that make up the quality handoff that we aspire for. Leaving the room is always like a question of like, when is the right time? You know, you can never summarize the case too much. No one has ever been like, they were too clear. I was too informed on what happened. And so making sure that everyone is on the same page is got to be critical. I always, as a general rule, when I'm leaving a rapid response, make sure I have a little huddle with the bedside nurse and the stat nurse. Rephrase what we think is going on, what our plan is, and make sure everyone is on the same page. And I ask for ideas. How does this sound to you guys? What other ideas do you have? If you don't have the buy-in of the bedside nurse and the stat nurse, you don't have a workable plan, okay? And so that has to be revised. Their buy-in is incumbent upon you being able to leave the room and that patient remaining on the floor. And of course, this any type of rapid response, would be a major event for that patient. And so you'd want to document that in some form. You need to like share what happened and what you guys did as a result. Now, we do want to take you through this a resource. There can be, again, rapid responses are challenging, and we want to give you tools, not only some cognitive tools in terms of a curriculum that I'm going to talk about in a minute, but also with the Occam reference toolkit. So this is a toolkit you guys may be familiar with. It's an app that you can download and then get subsequent toolkits within this. There is one that's widely used within the UW system on antibiotics that you might be already familiar with, or some of our colleagues may be sharing more with you. But I'm here to talk to you about the Rapid Response Toolkit, and I think like this is a very, very useful toolkit. Alex and I have actually done simulations with people in your shoes, interns, and putting them in simulations of a patient going into anaphylactic shock and then managing an unstable tachyarrhythmia. And the interns who use this toolkit without any training were able to get to the right medication quicker by an order of minutes. So really like a clinically significant time difference. And so as you can see, when you kind of download this over on the left side of the screen, you can see that there's a major broad categories of rapid responses: altered mental status, shock, respiratory distress, arrhythmia. Your first job is to kind of like think about like what bucket of rapid response am I in, and then once you kind of like think like, okay, my patient is in shock, they're hypotensive. You click on that, and then it'll open up, and you can kind of get a little bit more specific. You can, if you're able to identify like, I think this patient is in septic shock, cardiogenic shock, or hypovolemic shock. But also there is an undifferentiated option for each one of these. You click on that. And then there's an initial management toolkit. So ideas about stabilizing, focus history. This is a cognitive prompt to help you when you are in that moment when you're like, we've all been there. You get into the room and your mind goes blank, okay? So this is a tool to help you navigate those first few minutes, right? And then if you're getting even more specific, like, okay, this patient is having a seizure. I'm trying to find out what the medication is. This is a medication where we have looked up, these are the correct doses of medications. This is going to get you to the medication for a specific indication a lot faster than trying to scroll through all the text of UpToDate or another resource. So I'd highly recommend downloading this and getting this. An added feature is also, I'm kind of jealous because this doesn't actually apply to the VA where I am, but there are emergency response teams. So you can click on this and then move on to the hospital you're at, and you can actually call these specific teams through the app. And so that's an added feature that can really help you get the tool really, really quickly. In terms of when you're downloading the app, you get to the, like I mentioned, like a lot of people might be familiar with the antibiotic reference kit. You're going to click on this top part here, which will allow you to open up the rapid response toolkit, look at what you've downloaded here, and then you can actually download it so that, if you're in an elevator or wherever you are, if the internet goes down, you will still have the information you need to be able to support your patients. Again, we're happy to get feedback on the toolkit, but the experience and the feedback that we've gotten so far is a highly useful tool to basically help you get the information you need to be able to advance care. And then, as with so many things, as you guys are already, I'm sure, getting very well familiar with, the documentation is important. If it wasn't like documented, it didn't happen, is quite simply how it generally works. But there's also really practical reasons like that we need to do this. Like this is a situation where a patient became acutely ill, and we need important communication between two team members. Like rapid responses happen at night, and the day team comes and they're like, what happened? Like, I need to make sense of this. And so other folks on who are taking care of the patient need to know. It's an opportunity for you to help explain what you were thinking from a diagnostic and therapeutic standpoint. It helps with sign out, and there's no way to get around it. There is a medical legal component of this, that this is could be an important, potentially, transformative point in a patient's hospitalization or medical care, and we need to have some documentation to understand what happened. Again, there are tools for this. There are rapid response note templates in Epic. There is one at the VA as well, and they kind of like help guide you through what you're thinking about. You can even type in some. There are like keys that kind of help you like prompt you in terms of some other thinking, and so these are other tools that can help not only like after you're help you with documenting, but honestly can also help as a cognitive aids to like what is the exhaustive list of all the things I want to do for my patient with altered mental status once I've kind of ruled out, but helps you kind of organize and formulate our thinking, understanding that like these are stressful. And then also it's not as if all of your other work is going to stop just because you're having this rapid response. So we want to have these like supports to be able to make this workable so that we can not only have you guys taking excellent care of our patient, but you can actually move ahead and learn something from it. And while in addition to carrying on all of your other responsibilities. Thinking about how do we learn this, it's one thing for us to like have a lecture here and for you guys to tune in here, and so appreciative to have your time and attention. But I think we can all agree that like the actual act of like getting into a rapid response like is still a big jump. And like all of the things in terms of like medical decision making and communication, there's a lot of skills. And so while we think this is an awesome platform to introduce the ideas, we think like we still have work to do together to be able to get everybody on the same page and to get those skills to be managing rapid responses well. And so that's the Intern Rapid Response Simulation program that Alex and I co-facilitate that you all will be participating throughout this year. And we have a bunch of goals in this. We have non-technical goals. These are like, we want you guys to be deliberate and active in practicing the skills of leadership, communication, teamwork. And it is like a core objective of us. We want you guys to be like improving or increasing your confidence in managing a rapid response. It's not helpful for the patient, for our providers to not feel as though they are able to operate in this setting. So we want to increase your confidence in this. And we do have some like objective technical skills. We want you to be able to like feel more comfortable with equipment, the defibrillator, putting pads on patient, oxygen, medical knowledge. Like what are the medications you need to use for this situation? What are the doses? What are the diagnostic skills that you need to be looking at? What are the tests you should order? How should you interpret that? And the way we do this is we have 5. They are fun. They are so fun. I really look forward to these 5 fun sessions at each site. So about every other month, starting in October, we have a simulation that occurs at all 3 sites. So in October, there's going to be a simulation. It's going to occur at the VA, Harborview, and Montlake. And everyone, all the interns will be invited to participate. We're going to go through the 4 most common rapid causes of a rapid response to really help give you that framework and to have you practice these skills of how do we communicate in these settings. We're really trying to simulate in a safe and supportive environment some of that cognitive load of like working through challenging situations where you are trying to take care of a patient and there is a lot of coming at you. As one of our colleagues mentioned, like these can be chaotic. And so in a like scaffolded, methodical and intentional way, we're trying to slowly increase that chaotic nature so that you can learn how to navigate it successfully. We do have video modules that the video that we shared with was actually part of one. And so what you can expect is to hear from me about a week or 2 before every simulation. You're going to get an email that'll share logistic information about like, hey, at Harborview, the simulation is going to be happening at this time on this date. Meet at this room ahead of time. At the VA, it's going to be here. There's also going to be video modules in each one of these. These are like 5 to 7 minute videos. And they're meant to give you an opportunity to prime you in terms of what is the topic, but also to share some of those examples of high quality rapid response leading in terms of communication and teamwork, to give you that example so you can like have an example of what closed loop communication might look like in a stressful situation. I want to emulate that aspect of the communication, and then you will have the opportunity to apply that in a rapid response just about a week later. These are some of your some of our colleagues who have been in the rapid response. I'm actually looking at all these, and I think like all of these folks are actually like attendings and fellows now. We have been doing this rapid response simulation for a while. But these are at some of the different sites, and to kind of gives you a flavor of like, we are using a simulator for these. You know, there you can get the vitals, and we're getting diagnostic information. We try to make it as high fidelity as possible. And in between, each sim is going to have each session is going to have 2 simulations, and in between each, we do provide you with a chalk talk and a framework how to approach that specific idea. So thinking about like arrhythmias, thinking about shock, respiratory distress, altered mental status. We try to give you a framework. So when you go into that rapid response with your altered patient, with your hypotensive patient, you have a framework for how you're going to go through it and approach that patient in a systematic way so that we're not just super stressed and we're able to advance care. I am super excited to partner with all of you guys. I'm super excited for you guys to be joining us for this for the simulations, and really appreciate your time and attention today. We're happy to take any questions. We appreciate any feedback that you have using the QR code that is displayed here. And I think we have about 5 minutes. If anyone has any questions, Alex and I would be more than happy to chat.